Sleep-related breathing disorders are characterized by abnormal breathing patterns during sleep and include 1. Obstructive sleep apnea syndrome, 2. Central sleep apnea syndrome, 3. Mixed sleep apnea syndrome, and 4. Sleep-related hypoventilation and hypoxemia syndromes. According to the American Academy of Sleep Medicine, the AASM, sleep disorders can be classified into 8 major groups. According to the American Academy of Sleep Medicine, sleep disorder categories are as follows: sleep-related breathing disorders, insomnia, hypersomnias of central origin, circadian rhythm sleep disorders, parasomnias, sleep-related movement disorders, isolated symptoms and normal variants, other sleep disorders. Obstructive sleep apnea is a common sleep disorder that often requires lifelong care. Cardinal features include obstructive apneas, hypopneas, and respiratory effort-related arousals, which are caused by recurring collapse of the upper airway during sleep. During the periods of airway obstruction, patients commonly appear quiet and still as though they are holding their breath, followed by increasingly desperate efforts to inhale. Often the apneic episodes ends only after intense struggle. A snorting sound called fractive breathing may be heard at the end of apneic periods. In severe cases, the patient may suddenly awaken, sit upright in bed, and gasp for air. Patients with OSA usually demonstrate perfectly normal and regular breathing patterns when awake. In fact, a large number of patients with OSA demonstrate what is commonly called the Pickwickian syndrome, named after the character of Charles Dickens. The posthumous papers of the Pickwickian Club, published in 1837. Dickens' description of Joe, the fat boy, who snored and had excessive daytime sleepiness, included many of the classic features of which is now recognized as sleep apnea syndrome with hypercapnia or obesity hypoventilation syndrome. It should be noted, however, that many patients with sleep apnea are not obese, and therefore clinical suspicion should not be limited to this group. Central sleep apnea is a disorder characterized by the repetitive stopping or reduction of both airflow and ventilatory effort during sleep. Central sleep apnea can be classified as primary central sleep apnea, which is idiopathic or of unknown cause, or secondary sleep apnea. Examples of conditions associated with secondary sleep apnea include Cheyne-Stokes breathing, which is seen in congested heart failure, and medical conditions such as encephalitis, brainstem neoplasms, brainstem infarction, spinal surgery, hypothyroidism, drug or substance abuse, and high altitude periodical breathing. Central sleep apnea is further characterized as either hyperventilation-related central sleep apnea or hypoventilation-related central sleep apnea. Hyperventilation-related central sleep apnea is the most common. It includes primary central sleep apnea and central sleep apnea associated with Cheyne-Stokes respiration pattern breathing conditions seen in congested heart failure or high altitude periodical breathing. Patients with hyperventilation-related central sleep apnea develop alternating cycles of apneas or hypopneas with hyperpnea during the sleep. As a result, this condition produces a sequence of abnormal respiratory efforts, including periods of ventilatory overshoot, hypocapnia, central apnea, hypercapnia, and recurrent hypertnia. Carbon dioxide sensing is fundamental to this process as opposed to hypoventilatory central sleep apnea. This group does not have an elevated baseline carbon dioxide. Hypoventilation related central sleep apnea is usually a secondary problem related to underlying condition such as a central nervous system disease, central nervous system suppression drugs or substances such as alcohol, or acute use of opiates, barbiturates, or benzodiazepines. Neuromuscular disease, such as in Guillain-Barré syndrome or myasthenia gravis, or severe disorders of pulmonary mechanics, which are seen in COPD. During sleep, the patient no longer has the wakefulness stimulus to breathe, and as a result, alveolar hypoventilation and central apnea occur. The patient's breathing is restored during arousal from sleep, but again decreases when sleep resumes, resulting in cyclic periods of normal ventilation, hypoventilation, and apnea. The choice of therapy is based on whether the patient's central apneas are hyperventilation or hypoventilation related. Mixed apnea is a combination of obstructive sleep apnea and central sleep apnea. These episodes are events and not a condition. It usually begins as central apnea followed by an onset of ventilatory effort without airflow, secondary to obstruction apnea. Clinically, patients with predominantly mixed apnea are classified and treated as having OSA. In the picture to the right, the patterns of airflow, respiratory effort, which is illustrated and displayed through esophageal pressure tracing, and oxygen saturation in central obstructive and mixed apneas is displayed in this picture. Respiratory effort is classically measured from effort detections, which are bands or sensors placed around the thorax and or abdomen. It is essential that the respiratory therapist recognize the difference among these three entities. Sleep-related hypoventilation and hypoxemia syndromes include a broad range of sleep disorders. Some are quite common, such as obesity hypoventilation syndrome, also called Pickwickian syndrome, or coexisting with COPD, the overlap syndrome. Others are rather rare, such as congenital central hypoventilation syndrome and neuromuscular and chest wall disorders. However, all share the characteristic of abnormal gas exchange that worsens or may be present only during sleep or sedation. Such abnormalities are usually caused by hypoventilation and result in hypercapnia and hypoxemia. Pulmonary disorders, such as chronic bronchitis or emphysema, are not considered standalone sleep-related breathing disorders. However, they are known to cause hypoventilation and hypercapnia and hypoxemia during sleep. In these cases, the diagnosis of sleep-related hypoventilation or hypoxemia should be considered. Unfortunately, the diagnosis of the overlap syndrome is often missed in critically ill hospitalized patients. The diagnosis of obstructive sleep apnea begins with a comprehensive sleep evaluation, which includes a history from the patient and or the patient's bed partner, especially noting the presence of snoring, sleep fragmentation, periods of apnea during sleep, non-refreshing sleep, and persistent daytime sleepiness. The Epworth Sleepiness Scale is routinely used as a validated measure of daytime sleepiness. Sleepiness must be differentiated from fatigue, which can be semi-quantitated with the use of a fatigue severity scale or the visual analog scale. This followed by a careful examination of the upper airway and perhaps by the pulmonary function studies, especially by analysis of the flow volume loop, to determine whether upper airway obstruction is present. Abnormalities in the posterior pharynx include a large uvula, enlarged tonsils, a long soft palate, redundant lateral pharyngeal walls, macroglossia, and the presence of overbite of the upper teeth with a posterior placement of the mandible. The Millipatti classification score is frequently used in physicians' notes to describe abnormalities of the soft palate and uvula. The patient's blood should be evaluated for the presence of polycythemia, reduced thyroid function, and bicarbonate retention. Arterial blood gas values may be obtained to determine resting, wakeful oxygenation, and acid-base status. When possible, a carboxyhemoglobin level should be obtained. It should be noted that the pulse oximeter used routinely in polysomnography assumes the patient has a normal hemoglobin, PaO2 and SpO2 relationship. If carboxyhemoglobin is present, it should be subtracted from the pulse oximeter reading. For example, if the saturation is reading 90% and the patient has a carboxyhemoglobin of 7%, we would have 90 minus 7 equals 83%. A chest x-ray film, electrocardiogram, and echocardiogram are helpful in evaluating the presence of pulmonary hypertension, the state of right and left ventricular compensation, cardiac arrhythmia, and the presence of any other cardiopulmonary disease. Finally, in patients suspected of having sleep apnea, the diagnosis and type of sleep apnea are confirmed by either polysomnography or an in-home portable monitoring. Polysomnography is a specialized sleep test that monitors and records a number of physiologic parameters that occur during sleep. The test result is called a polysomnogram, which is also abbreviated PSG. The polysomnography may be administered as either a full night attended in laboratory polysomnography or a split night attended in laboratory polysomnography. The full night attended in laboratory polysomnography is considered the gold standard diagnostic test for OSA. It is performed on selected patients overnight in a sleep laboratory with a technologist in attendance. In a split night attended in laboratory polysomnography, the diagnosis of OSA is established during the first portion of the study, followed by a form of positive airway pressure treatment called CPAP, titration polysomnography. The positive airway pressure is applied to prevent upper airway obstruction or central airway apneas during sleep for the remaining time. This test is both diagnostic and therapeutic. Because the perceived cost of effectiveness, there is a growing trend to perform split night studies if the patient's total sleep time allows. Central sleep apnea is diagnosed when the majority of the respiratory events are central apnea or hypopneas. On the PSG, there is an absence of nasal or oral airflow and the thoracoabdominal movements. Patients diagnosed with central sleep apnea are evaluated carefully for the presence of cardiac disease and lesions involving the cerebral cortex and the brainstem. Atrial fibrillation is also associated with central sleep apnea. The treatment for central sleep apnea depends on its specific cause. The American Association of Sleep Medicine endorses in-home unattended portable monitoring, commonly called a home sleep test, as a reasonable cost-effective alternative for patients who have high likelihood of either moderate or severe OSA. According to their guidelines, a home sleep test for the diagnosis of OSA should be performed only in conjunction with a comprehensive clinical sleep evaluation supervised by a practitioner with board certification in sleep medicine or eligible for the sleep medicine certification examination. The advantages of a home sleep test are it can be done in the patient's home and or in an area that do not have easy access to a sleep center.
It's convenient. Patient acceptance. Easily can be performed over multiple nights. Decreased costs. The disadvantages of a home sleep test are absence of a trained technologist to correct and clarify recording artifacts and make ongoing equipment adjustments, inability to intervene in medically unstable patients, possible data loss or distortion, the potential for interpretation errors resulting from limited data, inability to perform subsequent multiple sleep latency testing according to standard protocol, varied sensor technology, and no published standards for scoring or interpretation.
Obviously, pulmonary function cannot easily be studied during sleep. However, patients with OSA may demonstrate a sawtooth pattern on maximal inspiratory and expiratory flow volume loops, as shown in this flow volume loop in this slide. The expiratory limb of the flow volume loop shows fluttering in the mid-flow portion. This vibratory motion or fluttering of the soft palate is known as a sawtooth pattern, which is indicated by the red arrow. The sawtooth pattern may be seen during obstructive sleep apnea. The arrow highlights the airway fluttering during exhalation. Note, similarly, both but less pronounced inspiratory fluttering. Contemporary pulmonary function testing equipment tends to smooth the expiratory fluttering that is characteristic of the phenomena. The absence of sawtoothing does not exclude sleep apnea, and neither does its presence rule it in. If present, sawtoothing should prompt a clinician to consider OSA and consider further testing. Also characteristic of OSA is a ratio of expiratory to inspiratory flow rates at 50% of the vital capacity. This is noted as FEF 50% over FIF 50%. That exceeds 1.0 in the absence of obstructive pulmonary disease. Radiological findings, the chest radiograph, may be normal or show right or left-sided heart failure. Because the pulmonary hypertension and polycythemia is associated with persistent periods of apnea, and right and or left-sided heart failure may develop. This condition may be identified as an enlargement of the heart on a chest radiograph or on an echocardiogram and may help in the diagnosis. The presence of upper airway obstruction during apneic episodes often is accompanied by bradycardia and a temporary reduction in cardiac output. This is unusual because hypoxemia usually causes tachycardia. In sleep apnea, oxygen transport falls and results in electrocardiographic brady-tachy syndrome episodes and swings in heart rate and blood pressure secondary to surges of adrenaline in an attempt to compensate for tissue hypoxia. In severe cases of sleep apnea, sudden arrhythmia-related death is always possible. Periods of apnea commonly are associated with sinus arrhythmia, sinus bradycardia, and sinus pauses longer than 2 seconds. The extent of sinus bradycardia is directly related to the severity of the oxygen desaturation. Obstructive apneas usually are associated with the greatest degree of cardiac slowing. To a lesser extent, atrioventricular heart block, premature ventricular contractions, and ventricular tachycardia are also seen. Apnea-related ventricular tachycardia is viewed as a life-threatening event. Atrial fibrillation is extremely common in central sleep apnea. Once the diagnosis of OSA is confirmed and its severity determined, the patient should be educated about the risk factors, natural history, and long-term consequence of OSA.
Importantly, the patient should be warned about potential danger and consequences of driving or operating other equipment or tools while sleepy. The types of therapy for OSA include the following. Behavior modification is indicated for all patients who have OSA and modifiable risk factors. Helpful behavior modification includes weight loss if overweight or obese, exercise, changing sleep positions. For example, OSA often worsens in a supine position, abstaining from alcohol, and avoidance of certain medications when possible. For example, medications that inhibit the central nervous system, such as benzodiazepines. Positive airway pressure therapy is considered the first-line therapy for OSA. As discussed earlier, the cause of many cases of OSA is related to an anatomical malconfiguration of the pharynx and the decreased muscle tone that normally develops in the pharynx during REM sleep. When the patient with OSA inhales, the pharyngeal muscles and the surrounding tissues are sucked inward as a result of the negative airway pressure generated by the contracting diaphragm. Positive airway pressure is useful in preventing the collapse of the hypotonic and obstructive airway and is the standard treatment for most cases of OSA. Positive airway pressure can be delivered as continuous positive airway pressure, which is CPAP, bilevel positive airway pressure, which is BiPAP, auto-titrating positive airway pressure, which is APAP, or PEEP, positive end expiratory pressure. Most oral appliances fall under one of the following two categories: a mandibular repositioning device or a tongue retaining device. The mandibular repositioning devices are the most common or popular. They are designed to reposition the mandible forward and downward slightly. The tongue retaining devices hold the tongue in a more anterior portion. Either design works to position the soft tissue of the oropharynx away from the posterior pharyngeal wall. Recent literature has been increasingly favorable toward the use of appliances in carefully selected, carefully fitted patients. Surgery is most effective in non-obese patients who have OSA because of the severe surgical correctable upper airway obstruction lesion. For example, a tonsillectomy is a reasonable approach in a patient with OSA caused by tonsillar hypertrophy, particularly in children but occasionally in adults. In patients without a strictly defined anatomical lesion, a uvulopalatopharyngeoplasty (UPPP) is one of the most common surgical procedures used to treat snoring and sleep apnea. The posterior third of the soft palate and the uvula are removed. The pillars of the palatoglossal arch and the palatopharyngeal arch are tied together, and the tonsils are removed, if present. As much excess lateral posterior wall tissue is removed as possible. The successful rate of this type of surgery is 30 to 50%. Laser-assisted uvulopalatoplasty and radiofrequency ablation are less invasive alternatives to UPPP. Other possible surgical procedures for OSA include septoplasty, rhinoplasty, nasal turbinate reduction, nasal polypectomy, palatal advancement, pharyngeoplasty, adenolectomy, palatal implants, tongue reduction, laryngeal tonsillectomy, genoglossus advancement, and maxillomandibular advancement. Recently, studies have shown the effectiveness of implantable upper airway stimulator devices that stimulates the hypoglossal nerve, which is the 12th cranial nerve, in turn activates the glossal muscle, the tongue, in contact with and increase the patency of the upper airway. In selected patients who are refractory to CPAP therapy and in whom complete concentric collapse of the retropalatal airway can be demonstrated during drug-induced sleep endoscopy, this technique shows promise. For all patients diagnosed with central sleep apnea, the initial treatment is directed at the conditions that may be causing the sleep apnea, for example, congested heart failure, encephalitis, and brainstem neoplasm. If the central sleep apnea continues after such therapy, management is then based on whether the patient has hyperventilation-related central sleep apnea or hypoventilation-related central sleep apnea. Similarly, OSA CPAP has customarily been the first-line therapy for patients with hyperventilation-related central sleep apnea. Patients who do not respond well to CPAP should receive a trial of adaptive servoventilation (ASV) with the variable positive airway pressure adapt, which is VPAP adapt. Adaptive servoventilation (ASV) provides the ventilator support to treat all forms of central sleep apnea, mixed apnea, and periodical breathing. The VPAP, variable positive airway pressure adapt, responds by increasing pressure support during a central event when the patient's minute ventilation falls below his or her target ventilation, which is 90% of the patient's minute ventilation. To determine the degree of pressure support, the ASV algorithm continuously calculates target ventilation. For patients who do not tolerate CPAP or ASV, a trial period of BiPAP with a backup ventilatory rate is suggested before abandoning CPAP. The use of BiPAP is recommended only for patients with hyperventilation-related central sleep apnea after CPAP and ASV has failed. BiPAP in these patients should be used only with the backup respiratory rate. This is because the BiPAP with a set rate may overventilate the patient during periods of normal breathing or hyperpnea, causing discomfort and arousals. It can even cause more central sleep apnea events. ASV should not be used in patients with heart failure who have an ejection fraction below 45%. Other treatments for sleep apnea. Oxygen therapy. Oxygen therapy is used for the treatment of sleep apnea because of the hypoxemia-related cardiopulmonary complications of sleep apnea, such as arrhythmias and pulmonary hypertension. Nocturnal low-flow oxygen therapy is sometimes used alone to offset or minimize the oxygen desaturation. The reasoning behind the effectiveness of nasal oxygen therapy is that the airway is continuously flooded with oxygen, which will be inspired during the non-apneic episodes, in effect pre-oxygenating the patient in anticipation of the apneic events. Usually, no improvement in sleep fragmentation or hypersomnolence occurs with the use of supplemental oxygen. All of the positive airway pressure devices that we talked about earlier generally use room air as an airway distending gas. Supplemental oxygen can be bled into any of them if the device-related manipulation of the pressures and the backup rate fail to adequately oxygenate the patient. Recent literature has called the whole concept of oxygen supplementation into question. At the present time, Medicare will not supply oxygen to patients with OSA unless it can be shown that the positive airway pressure therapy alone is insufficient. In any patient who does not tolerate or benefit from positive airway pressure or supplemental oxygen during sleep, a respiratory stimulant such as acetazolamide or theophylline may be tried in patients with central sleep apnea, although the results are extremely variable. The use of other pharmacological agents in OSA is at present experimental.